Welcome everybody to today's KI Library Professors Lecture. My name is Magnus Nilsson. I'm a professor of surgery at Cleantech here at KI Flemingsberg campus. I will now try to give you an overview, or at least a little flavor, of how gastric and esophageal cancer is managed today. And the title, or perhaps the motto of my presentation, is Heading for Less Invasive and More Effective Treatments. So let's see here. So a little bit about my background. I'm a surgeon working clinically with gastric and esophageal cancer every day, more or less. But I'm also a researcher working with clinical and translational studies on gastric and esophageal cancer management. And so what are the objectives of my work? Well, my goals is, first of all, to cure more patients. Ideally, we want to cure every single patient who gets gastric and esophageal cancer. But it's not enough. We also have to try to minimize the side effects of our treatment. The treatments are very, very invasive. They have a lot of side effects, and we really have to try to make the treatments more tolerable. And the third extremely important thing is short and long-term quality of life for these patients, which is a big, big problem currently. So a little bit about background for gastric cancer. Gastric cancer is currently the 6th most common cancer globally. It's the 5th most common cause of cancer-related deaths. There is one main subtype. There are subtypes, but it's adenocarcinoma, more or less all of the gastric cancers. And the main cause globally is Helicobacter pylori infection, which causes chronic gastritis and cancer. And because of the reduction in H. pylori prevalence around the world, gastric cancer has actually gone down in incidence a lot. It used to, up to about 20 years ago, be the #1 incident cancer in the world, actually. But now it's dropped to 5th place, which is a very good thing. A little bit about esophageal cancer. This is the 7th most common cancer, so it's also a quite common cancer globally. And there are 2 subtypes. There is squamous cell carcinoma and adenocarcinoma. And globally, it's more than 90% squamous cell cancer. And actually, adenocarcinoma used to be a very, very rare disease, but in the last 20 to 30 years, it has increased a lot in Western countries due to lifestyle factors, especially obesity and gastroesophageal reflux. Chronic inflammation in the esophagus is a very important risk factor. And as you can see in both these pictures, looking at the global incidence for esophageal cancer, we have the squamous cell cases here in Central and Eastern Asia and in Eastern Africa. While if we go back to gastric cancer, the main incidence areas are Asia and Western South America. And this correlates a lot to the prevalence of H. pylori infections. So, what is the current state of the art of management of gastric and esophageal cancer? Well, I have to say as a surgeon that surgery is still the main curative treatment. Most patients that we're going to cure, we have to operate them still. But there are several new treatments, and surgery alone is not the best treatment. Patients benefit from combination therapy with chemotherapy, or sometimes a combination of chemotherapy and radiotherapy before the surgery. And there's a third very important thing going on. There's recently been a description of a new molecular classification, which is extremely promising with regard to more tailored therapy. And looking at the surgery, we have had a lot of changes in the surgery in the last years, from all open, very, very traditional surgery to more technical, more minimal invasive surgery, and a lot of robotic innovations, and also AI concepts being introduced into the surgery. So surgery is changing very rapidly. And regarding the multimodality therapy, there is general evidence that it's an advantage to treat with chemotherapy or combination chemo-radio before surgery. But patient selection is very important. Some patients don't benefit from multimodality treatment due to the molecular subtype, and some patients cannot tolerate this very, very, very intense therapy with the first chemotherapy and then very, very invasive and difficult surgery for the patients. And the third concept, the molecular classification, this is really starting to change the way we treat the patients, but we're still very much in the beginning there. So let's go to the first part about surgery. So is less invasive surgery also more effective? What do you think? Are there any advantages? Well, the first minimal invasive surgery was performed in the UK by this gentleman, Sir Alfred Cuschieri, in the early 1990s. Despite his publication of this, it took many, many years before minimal invasive surgery in esophageal and gastric cancer became widespread. And it's only in the last 5 years that it's really, really spread around the world and become the most common type of operation for this type of disease. And what is the actual difference then between open surgery and minimal invasive surgery? Well, there are two main differences. It's about the entry wound trauma. If you do open surgery, you make very large incisions. You cause a lot of damage to the abdominal wall and to the thoracic wall. And operating esophageal cancer, you usually need access both to the abdomen and to the chest. So you make a really big incision in the abdomen and a really big incision in the chest. And with minimal invasive surgery, you make small incisions. So it's a lot less entry wound trauma. But the second thing, and I think this is at least as important, is the vision. You see so much better using a camera with minimal invasive surgery compared to using just your eyes in open surgery. And I'll show you something about this. So this is the entry wound trauma. Look at this thoracotomy, huge incision spreading the ribs. This is very traumatic. And look at the ports that we placed for a thoracoscopic procedure. And this is true both in the chest and the abdomen. Big incisions in both chest and abdomen compared to just placing a few very narrow ports in both chest and abdomen. So this is really big difference in entry wound trauma. Looking at vision, this is what we see in open surgery, although this is a little bit biased since we usually have headlights and we have some magnifying lenses, but still what we see is quite crude at a distance just with our eyes compared to what we see in minimal invasive surgery with high resolution cameras and 3D screens, and we can see anatomical structures that we didn't see at all in the open era. So this leads to more precise dissection. We can actually see the structures better and we can divide the tissue in a more precise way. And this leads to less bleeding, it leads to a potential for a better oncological dissection, and it leads to less unintentional tissue damage. And this is how the patient is positioned for the thoracoscopic part of the minimal invasive esophagectomy, lying in the prone position, that is lying on his belly. We have marked the scapula, some landmarks here, and the patient has an epidural catheter, that's why it's covered up there. And this is after placing the ports, so you can see it's 4 ports, 3 12mm and 1 5mm ports, so very small incisions. And now I'm going to show you how we place the first port, how we get into the chest in a minimal invasive procedure. We use a transparent port, it's of transparent plastic, and we have the camera here, we see it on a screen, and we can enter the port moving it back and forth. It's semi-blunt, so it's not traumatic towards any structures of the inside, and we can see our way through the thoracic wall into the pleural space. So I'm going to show you a little film here, how it looks, so you get a picture of what's happening. So here you see the fatty tissue in the subcutaneous area, the yellow part, and you see the muscle in the thoracic wall coming, and here you see now the lung actually on the inside. And then the port goes all the way in. You see the lung here, and then we're going to pull out the camera, or pull out the trocar, and in with the camera, and there we are on the inside. So this is the right pleural space. We're putting the other ports under visual control. So we see the 5mm port coming there. You see the ribs. You see the lung actually being ventilated there. This is the esophageal vein here. And we're opening the pleura with this ultrasonic vibrating instrument which cuts and seals vessels at the same time. You can see the esophageal vein there. Opening the pleura. and pushing the tissue. There's actually more or less never any bleeding in this type of procedure because we can so effectively see all the vessels and seal them before they ever bleed. Below here, the thoracic aorta can be seen to the pulse from the aorta. And we will be isolating the thoracic duct here in a while. Here you see the aortic wall, this part here, the white tissue there is the aorta. So this was just to give you a kind of a feeling of what it looks like in a minimal invasive procedures. We see structures that we never saw in open surgery. So, open or minimal invasive, which is better? What is the evidence? Well, there are some trials. There are actually 3 randomized trials that have been completed and published by now. And I'm going to take you through very quickly through 2 of them. This was the first trial published in the Lancet in 2012, the time trial. Minimal invasive, totally minimal invasive compared to totally open esophagectomy. It's a small explanatory trial using a surrogate variable, which is pulmonary complications. And looking at the outcomes, it was clearly positive, fewer pulmonary infections, 34% in the open to only 12% in the minimal invasive group, and also better quality of life at 6 weeks post-operatively, and the number of lymph nodes that were yielded from the dissection was the same as a surrogate marker for oncological benefit. And looking 1 year after surgery, the difference in quality of life was still retained. There was still better quality of life 1 year after surgery in the minimal invasive arm, because the patients after open surgery have a lot of many of them have pain from the thoracotomy. So this is a big difference. The second trial I'll tell you about was published just a few months ago in the New England Journal of Medicine. It's a trial comparing open esophagectomy to a hybrid minimal invasive, meaning doing a laparoscopic dissection in the abdomen, but actually open chest. So most people, including myself, didn't believe this would be such a big difference from open surgery. But it turned out that the difference was quite clear. The overall complications were 64 compared to 36% in the hybrid minimally invasive. And pulmonary complications were the most important difference here too. But even more intriguing, there was a difference in survival in the long term, which is maybe a little bit different to understand, just using 2 different techniques to do the same operation. But actually it's not so difficult to understand, because there's a lot of evidence that complications in surgery, in cancer surgery, leads to worse oncological outcomes. Patients who suffer from complications and take long time to recover, they will have immune systems that are not working as well, and they will have earlier cancer recurrence. So if we can take the patients through surgery with less complications, they're going to do better from the cancer. So 3 trials actually very consistently show less complications, quicker functional recovery, and quicker recovery of quality of life, and definitely no drawbacks in terms of oncological effects, probably better oncologically from this one trial. So now moving on to the second part, multimodality therapy, and I will be quite brief here, but there are a number of different types of adjunct therapy that you add to the surgery given in different parts of the world. The main therapies in the Western world for both gastric and esophageal cancer are either neoadjuvant chemoradiotherapy, that means giving radiotherapy in combination with quite low dose of chemotherapy to potentiate the radiotherapy before surgery and then operating, of course. And the other option is just giving chemotherapy before and after surgery. And this is the trial which really set the scene for chemoradiotherapy, the CROSS trial. It was first published in 2012 and then 2015, comparing neoadjuvant chemoradiotherapy to surgery alone. And it really showed a very, very clear survival benefit in adenocarcinoma, comparing these arms, but a striking advantage for squamous cell cancer, which seems to be more responsive both to chemotherapy and chemoradiotherapy. So this was a very important trial, and it really influenced the treatment around the world. The other option is chemotherapy alone, and then it's given both before surgery and after surgery. And this chemotherapy is much more intense than the one that is given in combination with radiotherapy. So this is very, very demanding therapy also for the patients. And the breakthrough for this kind of therapy was the MAGIC trial in 2006, and then it was confirmed in a French trial 2011. This is using platinum-based agents together with 5-FU. Recently, there was a trial called the FLOT4 trial, published in the Lancet earlier this year, which compared the MAGIC trial to a new triplet with docetaxel, which is a new drug in this field, and it really showed better effects. So FLOT is the standard of care for perioperative chemotherapy. But then, which is better, chemoradiotherapy or chemotherapy alone? Well, we don't really know. We performed a trial here in Scandinavia, a small trial. It didn't show any difference, but there are actually two very large ongoing trials, the NEO-AEGIS and the ESOPEC trials, two large European trials, each randomizing about 500 patients. And they will maybe show a difference, but I'm not sure we'll see a difference. Maybe they will show that they're equally good. What will we do then? Which therapy will we choose? Well, I think what we will do is tailor therapy. The future is not either chemo or chemoradio. The future is tailoring therapy and probably having new targeted therapies. And this moves us to the third part, the molecular tailored therapy part. So 2017, there was a Nature publication for the first time showing a very comprehensive classification of both gastric and esophageal cancer. And squamous cell cancer was classified into 3 different subtypes, while adenocarcinoma, both in the stomach and in the esophagus, was classified into 4 different subtypes. And you should look at this figure in relation to this side, that this is very high in the esophagus, this is in the gastroesophageal junction, and this is going down in the stomach. So you can see that in the proximal and mid-esophagus, it's almost only squamous cell cancer, while in the distal esophagus, there's more and more adenocarcinoma, because it's caused by reflux, by a change in the epithelium to columnar in the distal esophagus, and thus adenocarcinoma is developed. And you can see here that among the adenocarcinoma subtypes, the most common one is the chromosomally unstable one, which is 100% of the esophageal adenocarcinomas, but almost 50% also of the gastric cancers are this subtype. So it's more or less the same molecular subtype in the esophagus as half the gastric cancers. And it's characterized by a lot of copy number alterations, a lot of amplifications and deletions, and p53 mutations. The second one mentioned here is an Epstein-Barr virus associated cancer, which is confined only to the stomach, and it's quite rare. There's also a microsatellite unstable subtype, just similar to many other cancers, which is also confined to the stomach and a little bit to the GE junction area. And then the fourth subtype is called genomically stable, because there are very few copy alterations and quite few but consistent mutations. And this correlates very well to the diffuse type gastric cancer, which is very highly malignant. So what does this mean in terms of biomarkers? Well, the most established biomarker, which is actually used for tailored therapy, is HER2 amplification. There is very effective antibody treatment. There are several different ones when the patient has this HER2 amplification. Mostly it's used in palliative situations, but the patients sometimes have complete remissions from this treatment in combination with chemotherapy. Unfortunately, it's only about 30% of the chromosomally unstable patients who have this amplification, but these patients really benefit from this treatment. There's also a very promising group, the microsatellite unstable group, which may benefit from checkpoint inhibition therapy. And this is being tested in several trials now, and we hope that we will be able to pinpoint a subgroup, at least within the MSI group, which will benefit from this. Another very interesting finding was from a post hoc analysis from the MAGIC trial, which I mentioned earlier, the trial which paved the way for the perioperative chemotherapy. They analyzed the patients that were biobanked and looked at all the MSI patients, And it turned out that the MSI patients did not at all have any response from the chemotherapy. The specimens were totally without chemotherapy response. And looking at the survival of the MSI high patients, the ones that went to surgery alone had a very good prognosis without chemotherapy. But the patients that had chemotherapy, they all died because the chemotherapy delayed the surgery, and the chemotherapy was, tough on the patient's immune system, and the delay and the deterioration in combination were really bad for these patients. And this has been confirmed in a couple of other studies now, that MSI high patients with gastric and esophageal cancer, or within that group, they don't benefit at all from platinum 5-FU based chemotherapy. So to summarize a little bit, I have three main take-home messages. First of all, minimal invasive surgery has been proven to lead to less complications and quicker recovery, better quality of life, and maybe even better oncological long-term outcomes. Multimodality therapy is standard of care. Most patients benefit from combination therapy, but it's still uncertain which type of combination or multimodality therapy, with or without radiotherapy. And thirdly, and maybe most promising, we have a molecular classification which is a basis for coming biomarkers and coming tailored therapy. Thank you.